So my topic is on metastatic pheochromocytoma and abdominal paraganglioma. Yeah, so malignant pheos and paragangliomas, they are rare endocrine cancers. So all the pheochromocytoma paragangliomas are believed to harbor malignant potential. About 10 to 15% of the pheos and up to 50% of the abdominal paragangliomas will become metastatic. So what is the definition of a metastatic pheo? There's currently no histological, biochemical, molecular, or genetic marker that can clearly differentiate benign from malignant. So the definition of these malignancies rests on the presence of METs. The term malignant pheo and benign pheo from the 2004 WHO classification of endocrine tumors was abandoned in the current WHO classification of endotumor. So the term malignant is replaced with metastatic in this group of tumors. And metastatic pheoparaganglioma, this combination is known as PPGL is pheochromocytoma paraganglioma, is defined as such if the location is normally devoid of normal chromaffin cells. The regions where you don't find this and you find these chromaffin cells, then you think. So let me begin with the case. A 31-year-old female came with recurrent episodes of palpitations, headache, and vomiting since 6 months. Weight loss, 8 kgs in 6 months. Detected hypertension 5 months back. No family history. 24-hour urine metanephrines 3.24 milligrams per 24 hours high. Serum chromogranin high. CCT abdomen, it showed a retroperitoneal 7/8 enhancing lesion with areas of necrosis and hemorrhage. Post-contrast 140 HU. So it was suggestive of retroperitoneal paraganglioma. Now, is there a risk for METs in this patient? So coming to parasympathetic paragangliomas, also known as the glomus tumors, they are usually located in the head and neck, non-secretory. They rarely metastasize, less than 10%. They do produce actually hormones, especially they could produce dopamine. So mutations in the gene that code for the different subunits, the SDHA, B, C, and D of the succinate dehydrogenase enzymatic complex and its cofactor, SDHAF2, frequently predisposed to multifocal parasympathetic paragangliomas. Sympathetic paragangliomas are usually located in the chest, abdomen, and pelvis. They typically produce catecholamines, only noradrenaline, because you require the PNMT, and that's not there. And they exhibit higher rates of metastasis, up to 70%. So the parasympathetic, less than 10%, and sympathetic, up to 70%. So pheos usually release catecholamines, adrenaline, and noradrenaline, the pheochromocytoma, which is adrenal. Some are metastatic in 15 to 20%, so less often metastatic. Now, why do they produce adrenaline? Because they have the PNMT, the adrenal glands has the PNMT. So the typical metastatic sites are regional or distant lymph nodes, bone, liver, and lungs. Rarely, they can metastasize to the breast, ovaries, pancreas, brain, and skin. So are there any biochemical markers for METs? The best biochemical method for diagnosing pheoparaganglioma is plasma-free metanephrines and norepinephrines with a sensitivity of 90 to 100 and a specificity of 80 to 100%. What about chromogranin A? A sensitivity of 98% and specificity of 97%. The best combination of sensitivity and specificity is obtained by combining plasma chromogranin A and metanephrines. And this has been recently coupled to high pass scores and adverse clinical events. So probably a new non-invasive marker to assess metastatic potential if you have a high levels of both chromogranin A and METs. So methoxytyramine, a dopamine metabolite, it's measured in the plasma, has been shown to be an important biomarker for metastatic PPGL. So when you have metastatic PPGL, one of the markers we have to measure is methoxytyramine, which is a dopamine metabolite. And usually it points to mutations in SDHB, D, and C, SDHB being the main one. Up to 25% can have metastasis. Now coming back to a patient, does the patient require genetic testing? All paragangliomas are considered mostly heritable, are considered the most heritable of all the tumors. And all these paragangliomas must be referred for genetic consultation. Coming to the clusters, you have cluster 1, which is hypoxia-related cluster. Cluster 2 is kinase-driven cluster. Cluster 3 is overexpression of the Wnt signaling pathway. Cluster 4 is overexpression of adrenocortical genes. So cluster 1 is related to pathways associated to hypoxia. So you have in them mutations in the VHL and the SDHX gene family, mostly SDHB and D. They have a high risk for METs. And the most notable predictor of aggressive clinical behavior is the presence of SDHB mutations. And these mutations predispose the familial paraganglioma pheochromocytoma syndrome. This is tightly coupled to the development of abdominal paragangliomas that are often metastatic. SDHB immunochemistry has proven a valuable tool to triage cases for genetic testing. So coming to genetics in pheochromocytomaand, there's a strong link between mutations in the Krebs cycle related genes and metastatic properties. So if you have a germline mutations in mitochondrial 2 oxoglutarate malate carrier SLC25A11 or glutamic oxaloacetic transaminase 2 gene or dihydrolipomide S-succinyl transferase gene, they predispose to metastatic paragangliomas. Other non-mitochondrial related genetic aberrances coupled to metastatic paragangliomas include the mammal 3, that is the cluster 3, and somatic mutations in the STT2 and ATRX-entered promoter structural variants in non-coding. We don't do this. I think Nihal could throw light later on. What imaging methods are preferred in this patient? So we talked about genetic predisposition, which are the ones which are prone for metastasis. Coming to the imaging methods, CT scan is often the first modality on which an adrenal mass is detected. So there are some characteristics: spherical shape, sharp necrosis, ring sign are indications that a tumor is a pheo. It can be ruled out with 99% sensitivity if the HU is less than 10 on an unenhanced CT. Post-contrast, it's highly enhancing, usually more than 130 HU. MRI with diffusion imaging techniques can even detect small tumors down to 5 millimeters, high sensitivity, useful in children, pregnancy, or somebody is having a familial pheo or a genetic where you know that they'll have to be screened very often. In them, actually, MRI is good. And MRI is also good for non-adrenal lesions also. Functional imaging. So MIBG. So this is a norepinephrine analog accumulated in the adrenal medulla and the tumors originating from chromaffin tissue. MIBG with 123 iodine is used for detection and staging of PPGLs. Sensitivity between 28 to 100%, higher for pheos, 85 to 88%, lower for paragangliomas, specificity between 70 to 100%. So normally we have actually reduced the usage of this. The reason being, normal adrenals can also take up to 50 to 60%. And even the paragangliomas, 50 to 60% may not take up this MIBG. That's the reason. So we use it mainly if you have post-op cases, you want to look for residual disease, then you can actually look for this. Or in the adrenal, if the tumor is very large and we are sure there are some mets actually, then you can actually go for this. So in SDHX mutations carriers, sensitivity is lower than other imaging methods, especially in patients with thoracic paraganglioma. The other functional imaging include FDG PETs. This is useful for METs, especially of the SDHB1. Pheochromocytomas usually have increased yet often variable FDG uptake, low specificity. The other one is 11C hydroxyepidin PET, not universally available. Sensitivity for pheo and paraganglioma 96%. The good positive and a negative predictive value of 96 and 93 to 99% respectively, but then not available. This is the one which is coming up a lot, functional imaging. 68 gallium DOTATOC or DOTATATE PET targets mainly the somatostatin receptor 2. Sensitivity for metastatic PPGL is around 92 to 100%. So which imaging is preferred? I talked about the various imaging, which is the one which is preferred. Sporadic and inherited pheos NF1, the ret VHL max except the STH-X. 18 DOPA PET, first choice, the second choice being the dotatate, and the third being FTG PET. Extra-adenal sympathetic or multifocal or metastatic or STH mutation, dotatate PET, first choice. What are the predictors for metastasis? Size of the tumor. The moment you find a size of the primary tumor being more than 5 centimeters, location, extra-adenal especially, presence of STH-B mutation, sympathetic paragangliomas exhibit a high rate. I told up to 70%. So at the time of diagnosis, patients with any of these 3 clinical predictors of METs may benefit from functional imaging studies. Histology, well circumscribed. Classical architecture include an which is referred to as Zell-Ballen against a well-vascularized stoma. Tumor cell nuclei display a vesicular chromatin and visible nucleoli. Cytoplasm is often granular and intense basophilic. Invariably express neuroendocrine markers such as chromogranin A, synaptophysin, islet-1, INSM1. They are most often keratin negative and GATA3 positive with few exceptions. This is for. So is there a histological scoring for predicting aggressive biological behavior? Yes, you have what is known as a PASS scoring. That is a pheochromocytoma of the adrenal gland scaled score. It has a high negative predictive value. A value less than 4 almost always is associated to a benign clinical course. So you can see you have a total score of 20. Like you have a central or confluent necrosis 2 points, high cellularity 2 points, like that. Mitotic index 2 points, atypical mitosis 2 points. So overall you have 20, less than 4, we can say it's benign. Another one known as a gap algorithm, grading system for adrenal pheo and para, designed for both pheo and abdominal paraganglia. It expands on the PASS system by also including biochemical type. That's a type of catecholamine production and immunohistochemistry of Ki67 analysis. What are the treatment options? Surgery. More than 90% of patients with non-metastatic disease treated with surgery are alive 5 years after initial diagnosis. It could be open or laparoscopically. Now it's becoming more often laparoscopic. So this is selected on the basis of presence of clinical predictors of aggressiveness. In patients with subdiaphragmatic primary tumors larger than 5 centimeters, open lap preferred. It's also an option in patients with paraganglioma that have metastasized only to regional lymph nodes. Advantages in metastatic paraganglioma include improved survival after primary tumor resection in patients with distant mets. Resection substantially decreases symptoms of catecholamine excess, prevents potential complications related to the tumor's anatomical location, increases the efficacy of subsequent systemic therapies such as chemo and radiopharmaceuticals. Pre-op management, I will not go into this because you all know this. Yes. Now coming for management of hormonal manifestations. So metastatic paragangliomas are usually large. They have excessive amounts of catecholamines and many of them release dopamine. As you know, its excess does not lead to hormonal disease. So the catecholamine release is proportional to the tumor size. So hormonal manifestations are more overwhelming than in non-metastatic PPGL. Radiation therapy can palliate the primary tumors of metastatic head and neck paraganglioma, bone mets, or mets in location at high risk for complications, supraclavicular regions. Stereotactic radiosurgery, proton beam radiation therapy are helpful in treating skull base and neck paragangliomas. Stereotactic radiosurgery has also been used for metastatic paragangliomas that spread to the spine and other sites. Radiation therapy, epidural disease, and spinal cord displacement surgery is the first-line treatment, followed by stereotactic radiation surgery, followed by stereotactic. Coming to ablative procedure for local non-surgical management of metastatic pheo-para, radiofrequency ablation, cryoablation, or percutaneous ethanol ablation. So these may palliate metastasis-related pain, reduce catecholamine excess, and stabilize mets in critical anatomic locations. If you have a bone mets, you can give anti-disruptive with denosumab or bisphosphonate, especially zoledronic acid. What about the value of iodine 131 MIBG? So the value of this is mainly for treating this in metastatic is based on its affinity to the norepinephrine transporter located in the cell membrane of these tumors. You have two types, the low specific activity one and the high specific activity iodine 131 MIBG, and the one which is recommended by the FDA is the high specific activity. Indications are patients with progressive and unresectable MIBG await metastatic pheo or symptomatic disease that's not amenable to loco-regional control or difficult to control with alpha and beta blockers. And the clinical responses are expected to be inversely proportional to the size of the tumor. Adverse effects include bone marrow suppression, nausea, vomiting, fatigue, dizziness. Coming to chemotherapy, when do you use it? Unresectable and progressive metastatic pheochromocytomaand, especially in patients with high tumor burden and rapid progression. The usual one which has been used is the CVD, that is cyclophosphamide, vincristine, dacarbazine is the most common regimen used to treat this. You'll have to be very careful. Sometimes what happens when you give this, there's a destruction and there's a release of a lot of catecholamines, and it can produce what is known as catecholamine crisis, where the patient may go into a shock. And don't give up these patients. There's been instances where the patient recovered after 6 days because of the stunning effect which can happen. So don't ever give up when you give this therapy. Don't think the patient is dead. He could still recover and come. Temozolomide, orally administered drug that shares its active metabolite with dacarbazine, may be given as maintenance regimen to minimize risk of complication. It has been mainly efficacious in STHB carriers. Anti-angiogenic therapies. The metastatic one express angiogenic factors and the receptors, and subsequently these tumors are highly vascular. So they have tried tyrosine kinase inhibitors like axitinib, cabozantinib, lenvatinib, pazopanib, and sunitinib. Not so good results with this. HIF1 inhibitors, the cluster 1 ones. Abnormal activation of the hypoxia signaling pathway play a major role in the oncogenic potential of this. So especially they have used HIF2 antagonist has been evaluated for this. Then you have this DNA demethylating medication. The STHB mutations, they result in accumulation of succinate, which is an oncometabolite that results in DNA and histone hypermethylation. So they tried using decitabine, and guanidicitabine has been used in phase 2 trials. And then you have what is known as the peptide receptor radionuclide therapy. This uses a somatostatin analog coupled with radionuclide emitting beta radiation. And the radiopharmaceutical used is yttrium-90 labeled DOTAU, tyrosine 3 octreotide, DOTATOC, and 177 lutetium dotatate. Immunotherapy. So the pseudohypoxia, once again the cluster 1, may prevent the immune system recognition through inactivation of the cytotoxic T lymphocytes, activation of immune suppressive monocytes, and increased expression of immune checkpoint proteins, the PD-1 and the PDL1. So they have tried using the pembrolizumab, nivolumab, and interferon alpha. Similarly, mTOR inhibitors have also been tried. 2 small reports, some effects, not very convincing. So you can see the list of drugs which can be used actually. They have used ipilimumab, pembrolizumab, cabozantinib, pazopanib, sunitinib, cabozantinib, acting on the VEGF, you can see here. They even tried 131 MIBG, this is known. Cyclophosphamide, this is the one which acts at this level. And the radiopharmaceutical lutetium-177 dotatate. So you can target many things. So acting at the level of the M also, the everolimus has been tried. HIF2 alpha has been acted. Coming to the treatment decision. So I told about what are the choices available. So the treatment of patients with metastatic pheo is determined by several aspects: tumor burden and speed of progression, patient's symptoms and performance status, results of functional imaging studies, treatment availability and cost, and clinical experience. Patients with minimal or slow growth, they may benefit from observation or intervention such as anti-resorptive medication, surgery, or ablative procedure. Patients with progressive tumors, skeletal-related events, large tumor burden regardless of prior evidence of progression, or symptoms of hormonal excess not controlled with alpha or beta blocker need systemic therapy. So recommended first-line treatment for patients with metastatic pheo and paragangliomas. So if it is gallium avid, 120, you can use or 123 MIBG avid. You can use lutetium dotatate or MIBG 131 depending on the uptake intensity. If it is MIBG non-avid and gallium avid, lutetium 127. Non-gallium avid but MIBG avid, iodine 131 MIBG. Suppose they are non-avid to both of them. People have tried temozolomide if they have a low proliferative activity. And if you have a high proliferative activity, the CVD, cyclophosphamide, vincristine, and dacarbazine. A tumor growth of at least 20% when compared with baseline or the development of a new lesion over a period of 3 to 6 months indicate the need for systemic therapy. For abdominal paraganglioma or metastatic paragangliomas, dotatate therapy is more effective. In patients with very low proliferative activity, either wait and watch or primary treatment with long-acting somatostatin analogs may be considered. This is what you do. So you are treated them with alpha beta blocker, if possible, surgically debulk. If there is a rapid growth, chemotherapy with CVD. Slow to moderate growth, MIBG uptake is present, then you go for high dose MIBG treatment. MIBG uptake is not there, then you can go for novel targeted therapy. If it is slow to moderate, that is lutetium, dotatate radiotherapy, tyrosine kinase inhibitor, you can try. So once again, if there is no response to MIBG and no response to this rapid growth, go for chemotherapy. So to conclude, all pheo paraganglioma carry metastatic potential. That's the reason we require lifelong monitoring in these type of patients. All the paragangliomas require genetic workup. Advanced and progressive metastatic disease carry high morbidity and mortality. No curative treatment options are available. Clinical trials are identifying therapies that could alleviate disease burden. Thank you for patient hearing.
Thank you so much, Dr. Ganapathi. I think, if I look back at 40 years of my endocrinology, you won't believe it today. One single thing that has made a huge difference in cases like this is the evolution of imaging tools.
Yes.
We started, when I did my endocrinology in my younger days, not talking about post-graduation. For an adrenal tumor, we used to do an IVP and find out the location of the kidneys and at what level of vertebrae they were. Is the kidney pushed down? And then we'll think of an adrenal tumor. In fact, one of the cases I published from PGI in 1986, galacturia presentation as an adrenal carcinoma. And we did not even have, at that time, even an ultrasound available, making that diagnosis. And now, today, look at this refinement in the imaging tools, nuclear medicine tools, and then the hybrid forms of the nuclear medicine material, and picking up through the PET CT scans. That has revolutionized the thing. But with a caveat to the youngsters, many variations of normality are going to be labeled now as abnormal if we are not more than adequately treated, educated in these measuring tools. So in the long run, they stand a potential of causing more harm than good. Because, there are so many abnormalities that are a part of routine. You see, like if you take out routine specimens of thyroid, 10 to 12% people will have a tumor which would never be functional. The same thing would be about pituitary. I was just, when Nihal was making that wonderful presentation, incidental tumors, we see so many of them now, adrenals. So that judiciousness is now required, that containment, rather than, randomly making a decision, probably for the youngsters, that some experience needs to be inducted into making more, final decisions, like that adrenalectomy, like that hypophysectomy. Some maturity needs to be put in.
Actually, when we had just passed out, we thought MIBG was the gold standard. And now we came to know 50% of the normal adrenals will take up and 50 to 60% of the paragangliomas don't take up. And now for FDG PET, if the patient is on metformin, it will show a diffuse uptake in the intestine. So I think we must know all these negative things first.
Limitations.
Yes,
it's
limitations.
extremely important when you understand the progress of an investigation, understand its limitation. Now, I would like to make a comment before we'll take up some questions.
No, I think you're absolutely correct. I think we have to really go down to specifics when we look at these tumors. Ganapathi mentioned a few very important things when he talked about, I think one is histopathological scoring, second is the isotope therapy, and the third was chemotherapy. When it comes to histopath, he rightly said that the PAS score has a high negative predictive value, but actually has a very poor positive predictive value. The GAP score, and particularly two variables on it, one is chlamydia necrosis, and the other one is pseudo-roset formation. If you see those, your likelihood of relapse is actually much higher. But if you don't see any of these, you just have to play it by ear and follow up every patient at least on an annual basis. I mean, you might be perfectly asymptomatic after 1 year of treatment, but you should follow them up on an annual basis. The second thing is, which you mentioned about isotope therapy, one of the unfortunate practical things is that MIBG is becoming increasingly difficult to get. And there's a strange political quirk to this whole thing. Number one, of course, the market for lutetium has increased, and so obviously things are moving in that direction. The other one is the largest provider for isotopes from abroad was actually Iran at one point of time. Now, unfortunately, due to various political issues, we can't get isotopes from Iran anymore to India, and that's a very, very sad thing. And we are forced to buy more expensive isotopes from Europe and the US. Or Europe rather, not the US, France particularly. So that's also affected us in a big way. MIBG will, unfortunately, unless we really push hard, will die a natural death over the next few years. We'll be stuck with mainly lutetium, which is a shade more expensive. So that is how things are actually moving and progressing. The last one is, I think, chemotherapy for malignant Pheos and paragangliomas. The response, like you said, you put it last in the list, is kind of a last-ditch form of therapy. They really don't work particularly well. If you look at all the targeted immunotherapies available, the VEGF shows some promise, but most of the others, the TK inhibitors, etc., which work in other neuroendocrine tumors, don't seem to work particularly well in paraganglioma. So, if in a nutshell, I think these are the little bits of finer tuning which Dr. Zadgar is mentioning, that we need to know what to do, what not to do, and be very careful about these things. One of the other things, and I think that perhaps would be neuroendocrine tumors in general. Remember, if you have a local metastasis and it's not functional, they can last and live with it for many, many years. So just follow up, repeat isotope scanning once in 1 or 2 years. And sometimes when you give targeted immunotherapy, they become more sick with that. So better leave them alone and live with their metastasis for maybe even 10 years sometimes.
Couple of words, Mala, before we take over some of the questions. When you look at these rare things, and there is no harm in talking to a senior colleague up and down in the city or country up and down, because the experience, like now, Ganapathi just talked about the 2 cases of carcinoid with ectopic production of ACTH, and Nehal has a series. Sort of exchanging experience wouldn't be doing any harm to anybody. Just word up and down and might give an idea what needs to be done to a patient. And secondly, now this, what he also referred to this genetic assessment, particularly, if you are saying about 10 to 15% of these Pheos and paragangliomas would be malignant, 15 to 20% would be familial. And the chance of pregnancy in them would be much higher. So, and now many of the endocrine societies and hypertension societies have given definite guidelines when to go for by genetic testing. And it's becoming relatively simpler now. We used to find it very difficult to get those metanephrines and nephrines done. Now it's being done on the roadside. I'm sure in a similar fashion, if some of us start picking up those techniques of really getting those genetic assessments done, we might find, I'm not talking about a metastatic pheochromocytomas. Some pheochromocytomas, which we otherwise treat as essential hypertension. As Nal was saying, some of those metastases, which may keep on lingering on, from the biological point of view, the metastasis may not be that violent or invasive. a person may live for a decade or two. Mala, any questions there? Mute.
You're muted. You're muted.
Sorry. The questions are sort of repeated. Dr. Ganapathi has touched, but however, just for, again, you can reiterate, what is the best test to do for identifying it? You have mentioned, but you can just go ahead.
To begin with, we will actually do a CT. And then, as I told you, MIBG when to do. Suppose you have a large adrenal one more than 10 centimeters, or you have a METS. You're suspecting when you have more than 10 centimeters, what happens is there will be definitely METS. So for that reason, we'll do then. And then follow-up of these patients, then we do an MIBG. But otherwise, we go for a PET CT. And the PET CT, I told you, for the various mutations, you can either do a DOPA. The advantage of the DOPA is it is not taken up by the normal adrenal glands. So that's the advantage. Or you can do a dotatate. That's the one with gallium 68. This one, dotatate, is supposedly now coming in a big way, especially for the metastasis and all. So I think we should go with gallium, then the DOPA, and then last, if you don't have these, then you go for the FDG PET. This is mainly for metastasis only. Otherwise, it's not that useful, the FDG PET. So
and I suppose the initial blood test would be a free plasma and the chromogranin A before you go into the imaging. Thank you very much, Dr. Ganapathi, Dr. Abdul Zargar, as well as Dr. Nihal Thomas. It was a very excellent session and we had a good interaction among all the faculty.